Okay, good evening, everyone. Welcome back to ICM Masterclass. We're happy that you're here. I hope the participant number will rise a bit during the first minutes. Our today's topic is pulmonary embolism, and we got a very, very experienced physician, Domagoj Domjanovic. He's a physician in the University Medical Center in Freiburg. He's a consultant at the cardiac surgic ICU, and he's an anesthetist. And yeah, he's here for the fourth time. So since the beginning, we are very happy that he's telling us something about pulmonary embolism. And first of all, we show you the medical visit of the patient. And yeah, let's start.
Hello and welcome again to ICM Masterclass. Welcome back here to Mr. Johnson on our ICU, the polytrauma patient with a 2-time rupture of the spleen. In the last days we removed the chest tube, and due to pressing, the extubation of the patient didn't succeed so far. This morning he gets more and more tachycardic and tachypneic with a respiratory rate over 30. Also the blood pressure dropped and we need to give him catecholamines again. In the blood gas analyze, we've seen high CO2 of 56, so we had to increase the ventilator support and change to controlled ventilation, although the X-ray showed no infiltrates. After the doctor's visit, we're going to perform a heart ultrasound and a CT scan. And now, when we look on the curve, as just discussed, we had to restart some norepinephrine as well as dobutamine for the circulatory support. And as you can see, the norepinephrine is running at a rate of 0.05 microgram per kilogram per minute. Dobutamine is running at 4 microgram per kilogram per minute. Propofol is still running at 4 milliliters per hour. And remifentanil is running at 0.1 microgram per kilogram per minute. The baseline infusion is lactated ringer at 21 milliliters per hour, and as you can see, the volume bolus of 500 milliliters at 10 a.m. also for circulatory stabilization. The nutrition is still running at 84 milliliters per hour. The only other medication the patient is receiving is heparin for continuous anticoagulation at a rate of 2.7 milliliters per hour. If we now look at Mr. Johnson's current vital signs, we can see a marked tachycardia of 140 beats per minute and slightly reduced blood pressure under volume and catecholamine therapy. Also, his oxygenation situation is at the lower limit, and with a respiratory rate over 30, he's also very tachypneic. During the morning, we can detect a significant increase in the heart rate with an increasing hypotension, as already discussed. Overall, we're looking at the vital signs of a critical ill patient who requires a special level of attention and also intervention. Taking a general look at Mr. Johnson's curve, apart from the vital signs, we can only note unspectacular values, normal temperature, and also normal urine output. Looking at the ventilation parameters, we see the discussed switch to controlled ventilation to compensate Mr. Johnson's respiratory insufficiency. When we're looking at the blood gas analysis, we see on the one hand a respiratory global insufficiency, and on the other hand a pronounced combined respiratory and metabolic acidosis, which is an emergency and life-threatening condition and requires an acute intervention by the attending physician. The pH has dropped to 7.18, the PO2 to 55, and the PCO2 has increased to 56. and the metabolic derailment is reflected in a basic CES of -6 and the markedly elevated lactate of 7.9. So the other parameters are shown are currently still within the normal range, but could also deteriorate in the course of the disease, so that in such a case it makes sense to take blood gases regularly in order to detect the deterioration as early as possible. In the lab we can see a significant increase in the platelet count. The CRP is slightly recovering since the last lab. However, we can see normal renal function and coagulation under heparin therapy. Other than that, there's nothing special to report.
Okay, now I will hand over to Domagoj, and we are very, very happy that you're here. We like your session that much. You're very experienced in this topic, and yeah, I'm glad that our participants can learn from you and from your experience.
Okay, so thank you for the very kind introductory words, Stefan, and for the invitation that I can be here again. I really enjoyed this session, and I also very, very much appreciate the format of this teaching. I had the pleasure to be there from the very beginning, and it's an absolutely amazing idea to provide such a format to learners. So thank you very much for this. Hi, everyone, from my family holidays, actually. That means if the internet breaks down, I thank you for your patience. I will log on again with a backup option. But for now, we will be very optimistic. I'm starting to share my screen, and I would ask you to just give me a short sign when you see the screen, and especially that it's the correct presentation screen and not the previous screen. So just a second that I can switch it on. So need to start the presentation first, then go back to the Zoom call. And now you should see my presentation screen, so the full slide. Is that correct?
We do. We just see that presentation mode, no notes, and everything's fine.
And second thing is what I would ask the Homburg team again, as always, is that you help me read the chat, because while I present, I can hardly see the chat. So you will need to help me with questions and all things that come in via the chat in the Zoom call. Is that okay for you?
Of course we do. We check for questions, and if we can answer them on ourselves, we will do. Otherwise, we're gonna interrupt you.
Okay, thank you so much for that. So we are starting off. And the first spoiler of the whole session is, of course, you already have the solution, right? This is not a case that you need to solve like a detective, but from the very beginning, we know the solution. That is the topic of this evening is the venous thromboembolism. And that is something that is not always true in real life. You have a patient that is pretty bad, a crashing patient where you are called. And as we heard in the video, that is a patient that requires your immediate attention and intervention. Usually, just imagine you are the intensivist and you are called by a respiratory therapist or by a nurse to the patient's bedside, where you are not always, you're also on your computers doing the paperwork. And they call you and they just say that patient looks bad. And now we are in that situation and we have a crashing patient. And for today, we have the solution. We know it's all about thromboembolism. This lecture does not necessarily represent the views of my employer. I have been a part-time employee at a medical tech company in Freiburg who produce ECMO devices, and that does not constitute any kind of conflict of interest for today's topic. I would leave it to your discretion whether the fact that I'm an anesthesiologist, but I work for cardiac surgeons on their cardiosurgical ICU constitutes a conflict of interest or a confession of interest. Okay, so what I'd really love you to take away tonight is how to recognize venous thromboembolism, maybe some clues, some hints that will lead you to that diagnosis, because it's not always as clear as we have it today. And the most important thing that I would love you to take away is how venous thromboembolism, that is pulmonary embolism, harms your critically ill patient, and how you can save their lives in the very first minutes and hours, how to stabilize these crashing patients. We'll also talk about further treatment options, but that also means we cannot touch on everything because this is such a huge topic. So what we will not very much talk about is the different possibilities of prophylaxis of venous thromboembolism. So what kinds of agents can you administer to your patient? We won't talk very much about those guidelines on what to use best in which situation. And also, how do you treat your patient further after the initial stabilization? That means on the normal ward or in the weeks after. What does that mean for their life, having had a diagnosis of a pulmonary embolism? So we need to choose a topic. And as I am an intensivist, I will concentrate on these things. That means we will talk about massive and submassive pulmonary embolism and really crashing patients who are in immediate danger and who need your action stat. Okay, that means we will look a little bit into pathophysiology. We will look a bit into what you could do and what you should not do. We will go into diagnostics a bit, and we will touch on treatment options a bit, just to give you an idea how these things could look. Okay. It's a very good tradition in the meantime that, first of all, we go on a little holiday, right? There's so much stuff for your brain tonight. That means we need to relax a bit. And I would like to take you to my home country. As my name maybe suggests, is I am from Croatia, and Croatia has a beautiful seaside in the Adriatic Sea. But there is also a land portion, of course. And unfortunately, in that country, there was a war. You might know that in the beginning of the 90s, there was a homeland war there. And when you look at that region here, there is a strategically important bridge. It's called the Maslenica Bridge that connects the north with the south. I was a child by then, and as I was going to visit my grandparents, who were living even more south, and we traveled from Germany because we were growing up and living in Germany, we had to travel from north to south using that bridge. And guess what? In the wartime, that bridge was destroyed. And what that meant for all the people traveling from the north to the south is there was a route, a main supply route, that was now blocked. So all of the area here was not supplied well. And here it could happen that you got some congestion. And if we wanted to travel from the north to the south, we had to bypass that area very widely. That means we had to take some kind of ferry here and travel with a ferry and then go by a road again. So it's not too hard to get the analogy to our topic here, but maybe the thought of the beautiful seaside will help you remember these things better. Now, as we look back to our case presentation that we already heard, we have a person that is pretty sick. And we can look into some details of their patient record. I will switch to the record right now and zoom in on some things. And that will happen during the presentations for a few times. So what I will do is I will not only use PowerPoint, but we will go into the patient record specifics. We will go into the vital parameters, and I will try to have you really understand how does that documentation work? How does that paperwork go? Okay, that means we are switching a bit to the patient record. And that is, we've had a case presentation, and we were looking at Mr. Johnson, and he had a polytrauma. And I'll just recap a few things that we will focus on further, just for you to help you follow across the presentation. So now the patient is on some sort of catecholamines. They started at about 10 o'clock and they were increased in their dosage. He is also on some kind of sedation. This is propofol, and the sedation was also increased. He has received a fluid bolus. He has heparin already running. This is not only a prophylactic dose. This is a very, let's say, intermediate dosage of heparin. And there were some changes in the respirations. What we can see here is the blood gas analysis. And in the blood gas analysis, all those numbers that were black, which suggests that they are some kind of okayish, turned into red. So there was some kind of deterioration. Also, please note, you have already been working with this kind of record sample, that the lab values from the blood samples and the chemistry are going backwards. That means the most recent one is on the left and the earliest one is on the right. Okay, that means everything else goes opposite, older things left, newer things right, but in the lab values, the most recent things are on the left. Okay, so that is a little recap, and we will come back to that later. Now, going back to our presentation. Can you see my presentation, or is it just no, it's the old slide. I'm sorry for that. That switching will take us some time, but it's really important to work with all of the sources we have. Okay, so we are recapping. Mr. Johnson has become tachypneic. His saturations are dropping. He has become more tachycardic, and he has become more hypotensive and has an increasing vasopressor requirement to help him keep his blood pressure. And if we hadn't had the solution here that tells us, okay, it's a pulmonary embolism, clear things, we need to think, what could this be, right? So if you have all of these things and you see a bad respiration and a bad hemodynamics, that is a combination that is not always combined. Sometimes you just have one thing or the other. So here you have a combination. And that in itself is a very important clue. Do you have any other differential diagnoses that you think of and that you might want to work up and see whether there is something else going on?
So in the chat, there are some suggestions like infection, like pneumonia, ARDS, tension pneumo, bleeding, sepsis, pneumothorax, sepsis, acute lung edema, heart failure. Yeah.
Okay, thank you very much for this. That shows that you already know a lot of things, and I'm very excited that you got it that well very immediately. Now, let's remember you are the intensivist, and maybe I learned this is mainly a student's lecture. You're maybe last year medical students or across the whole study. But anyways, that means that you are confronted with a whole list of differential diagnoses. And if you haven't been doing intensive care for half of your life, then it's very hard to prioritize these differential diagnoses to see, okay, which ones are pretty probable and which ones are less probable. And you need to work up them very quickly, and you need to narrow down your differentials very quickly, because it's a matter of seconds and minutes sometimes in these patients that you need to move forward. And what is good for the one patient might be very harmful for the other patient. We will get back to that later, but that only shows in real life, when you don't have the title in the beginning telling you what the disease is, things are pretty hard, right? So we learned that now, and we confirmed it now, and we are moving on. Something that helps me up to today, and I've been doing this for, let's say, more than a decade now, is the ABCDE somatic or mnemonic. So that helps me to sort out things and sort out what to prioritize and how to move on and narrow down the differentials and how to act on all of these findings. So when we also move on with our very patient here, the physical exam shows us a left lower extremity edema, trace edema on the right. He has a red leg, a red swollen leg, actually. And if you have a neck, Mr. Johnson appears to be a pretty athletic person. If they have a neck that you can examine, you will find a jugular venous distension. They are diaphoretic and pale, and the patient is afebrile. That does not in itself exclude the diagnosis of a pneumogenic sepsis, which is very high on the differentials list, but it is some kind of little clue that might help you think, okay, maybe it's not really sepsis. Very much in young patients, you very often have a pretty pronounced feverish reaction. Okay, and then we have some kind of further workup. We have our diagnostic tools that we can use. And in pulmonary arterial embolism, you have very specific findings that will help us, of course, narrow down all those differentials very quickly. When we go to the ECG, we find some kind of unspecific changes. And some of you said could be a myocardial infarction in a young person. That is less probable, but in a very sick young person on ICU receiving anticoagulants, who is immobilized and who has all kinds of critical illnesses in combination, that can also happen. Okay, and now we have some ECG changes here, most pronounced here in the precordial leads, V1, V2, we have a ST depression. We have a very high R spike in V1, which tells you that the right ventricle is in trouble. So that could point you to some kind of right ventricular problem. We also have an S here, a deep S wave here, not so much a pronounced Q wave here, but that could also be some kind of finding on the ECG. And what I must say is, in all comers, an ECG that shows you a right heart problem can help you differentiate things. On my ward, I'm on a cardiosurgical ward. The ECG does not help me so much, but this is also a very specific patient group. Okay, I will skip that for now, and I will go on to lab values. If we use the lab to rule out pulmonary embolism in the emergency department, we always use D-dimers. They show you that we have some kind of activation of coagulation and clot degradation. But what is very important is that you can only rule out pulmonary embolism if they're negative. So if you have negative D-dimers, pulmonary arterial embolism is very, very improbable. That is true for the emergency department. If you look at your patient on the ICU who has had trauma and major surgery a few days ago, these values will definitely be elevated. And they will not be helpful in that patient, because you can bet that they are elevated, not because of the pulmonary embolism, but because, of course, the patient has already had bleeding, surgery, clotting activation, and clot degradation. So the D-dimer test is something that helps you maybe also in this patient in a few weeks, when you say, okay, now the surgery has been over for a few days and weeks, and now we've had normal D-dimers for a few days, and now they are elevated again. So now then it can help you a bit. Another lab value that will help us is the troponin. Troponin tells you that heart muscle is in trouble and that there is myocardial injury. Most of us are used to associate troponin, to relate troponin to myocardial ischemia and to myocardial infarction. And most of the time, that is also true. That again needs the clinical context and the medical history of the patient and all of the things. But in pulmonary embolism, it also has a role. In that case, we don't use it as a diagnostic test, like in myocardial infarction or in acute coronary syndrome. You use troponin to say, okay, I don't see ECG changes, but the patient has chest pain and the troponin is positive, then you would call it a non-occlusive myocardial infarction, or the older version, a non-STEMI, right? So you have found some kind of myocardial infarction in the blood sample, and then regardless ECG changes, you can say, okay, that there is something going on. In the context of pulmonary embolism, we use the troponin to see if heart muscle suffers from the pulmonary embolism. We will come back to that mechanism later, but it helps us with risk stratification. Okay, and the gold standard diagnostic test in pulmonary embolism is, of course, the CT angiography. So you have to transport the patient to the CT scanner, and you have to apply contrast media, and then you will find the clots in the pulmonary artery if they are there. These here are pretty massive and pretty central. This is the main bifurcation of the pulmonary artery. This is the left one, this is the right one, and that patient has bilateral central pulmonary emboli. That means this is the contrast media. It shows you where the blood flows freely. And here is a blockage, and the blood does not flow freely. Okay, so this is the diagnostic test of choice when you want to find or exclude pulmonary embolism. And of course, it will also show you other potential diagnoses. That means it can also show you an infiltrate, like for the pneumogenic sepsis, or other things that might compromise that patient. But of course, that means transportation, that means radiation, and that means application of contrast media. If we move on, we will use my pet peeve, that is point of care ultrasound. And this is really a game changer in bedside diagnostics of critically ill and crashing patients. And what you will look at is a heart view. These are abbreviations for two heart views. It's an apical four-chamber view, and a parasternal short axis view. And we will also look at lower extremities, and we will also look at the lung. Before we move on to the respective ultrasound images, this slide here tells you that it absolutely makes sense to do a multi-organ ultrasound in your crashing patient. And what that means is you don't just look at one organ. Just, you know, many of us are pretty busy with the heart and looking at the heart and doing some measurements and very complicated scannings and everything. But the main point is that your crashing patient on ICU with a lot of illnesses, and with the need that you narrow down the diagnosis quickly, that patient has findings on several organs that you can see with ultrasound. And the combination, so putting together all of these pieces, will help you understand what is going on in that patient. And by the way, this is also the most fun part of it. So let's go into the details. This is an apical 4-chamber view with a mobile ultrasound device. And what you can see here is the left ventricle on the right side of the screen, the right ventricle on the left side of the screen, and these are the atria here down. Okay, so, and if you observe the heart, the first thing that you can see is, what we always look, is that there is no pericardial effusion visible here. So it's not a tamponade, by the way. What you can also see is that the heart is pumping pretty excitedly, right? There is a lot of motion on the image. Of course, the transmission over the Zoom call is a little bit limited, but you also get limited ultrasound quality on the ICU at the bedside. So we are simulating this a bit right now. So you can see that there is a lot of motion here, and you could say that the left heart is hyperdynamic, right? So it's not a left heart problem. The left heart is doing its best to compensate for the real problem. And what we can see here is that the right heart is enlarged. It is, in fact, larger than the left heart. And that is not normal. Normally, it's the other way around. Normally, the right heart is up to 2/3 of left heart size. So the right heart is bigger than it should be. And that gives you a clue that it is compromised, that there is some kind of right heart strain. That's the correct expression.
There was just one question. Is it the McConnell sign?
We also see the McConnell sign. I'm sorry, someone is knocking at my door. I'll just be at the door for a second. Sorry for that. It is a little bit of the McConnell sign. Sorry. Passt schon, ist erledigt. Okay, I'm back. So that was a good idea. The McConnell sign means that you have a very hyperdynamic motion of the right heart up here. And this portion of the right ventricular free wall is a little bit more lazy, but you have a very pronounced motion of the tricuspid annular plane here. That means in that direction, there is a lot of motion as well. And that is maybe a little bit of the McConnell sign, but not a really pronounced one. That is also pretty much next level. And that would be a topic for another evening. Thank you for that question anyways. So if we see a McConnell sign, that is also a sign of right heart strain.
And there's another question. Does the ventilation perfusion scintigraphy play any role in the clinical routine of diagnosing pulmonary embolism?
I haven't seen one in 15 years. Okay, that's for its role. I think there is still some kind of role for that. If you have nuclear medicine at hand, it's not right next to the CT scanner, right? You need a gamma camera and all of these nuclear medicine things. You can do it in special cases. It's more useful in thoracic surgery to see what parts of the lung can be removed, you know, and all of these preoperative diagnostics, and in very special questions. But the mainstay remains the CT scan. So VentPerf Scinti is not something that I see a lot in my own clinical routine.
Okay.
The most important and the most well-known sign of the ultrasound is a parasternal short-axis scan, where you can see a round-shaped thick-walled left ventricle here, and you see the right ventricle here. Normally, this would be a figure of a donut here and a croissant here. And now you have a very small donut and a very big croissant. So you have right heart dilatation here again. And what that does is that it pushes the interventricular septum flat. Normally, the septum is round and bowed towards the right ventricle. Here, it is pushed flat because the right ventricle has a problem and strain. It dilates and it pushes the septum towards the left ventricle. What that means is that the filling of the left ventricle is impaired. And that again means that you can have a very bad blood pressure just because the left ventricle cannot do its work properly. Because this flattening of the septum with that round shape here resembles the letter D, this is also called a D sign.
This was also a question in the chat if it's the D sign.
Yeah, that is true. That is a really, really pronounced D sign. I'm just going back a few slides to give you another clue. So that is, I didn't draw it in there. You will find a lot of videos where they even draw the letter D so everyone understands, but you can have an idea that this here, the flat thing and the round thing gives you a D. Okay, and then for the multi-organ part, of course, you can also look at the leg and its venous vessels. And here we have the proof that there is venous thrombosis. This is the left leg in this case, but it could be both of the legs, where you scan the femoral vessels in the groin. And what is done here is a compression. So you push down your ultrasound probe. And what that makes is it has the artery collapse here. The artery with the pulsation collapses under the pressure, but the vein does not collapse at all. It remains as big as it was before. Normally, the vein has a lower pressure in it than the artery, and it has thinner walls, and it, of course, would collapse first under the pressure of the ultrasound probe. Now, you cannot always see the clot itself in the blood vessel. So some kind of material or some kind of hyperechogenic stuff there. Here you can see a little bit inside, but that's not always the case. That means that if you just see something black in the vein, that does not rule out a thrombosis, because thrombi can also be anechogenic in the ultrasound. That means you need to do the compression ultrasound. If the vein collapses, you have excluded thrombosis at this very spot. Now we have proof of venous leg thrombosis. We have seen right heart problems, and the combination of it tells you very much that pulmonary embolism could be this patient's problem. You can also have findings on lung ultrasound. Maybe you have already seen something on lung ultrasound regarding the search for pneumothorax. And now we have a finding of subpleural consolidations. So here we have the rib shadow, the rib and its shadow here. And we have identified our pleural line. And from the pleural line, we have some D lines here, but we also have that little consolidation close to the pleura. And it's about 0.5 centimeters. And that is something that could be a peripheral lung embolism. That's not something that is very useful in itself. So you don't go searching for these. And if you don't find some, that doesn't mean that it excludes pulmonary embolism. And if you see some, you need to look at the context, because some similar stuff can also appear in viral pneumonia, very small ones. But what I want to tell you is, if you see the combination of peripheral pulmonary embolisms on lung ultrasound, right heart problems, and deep vein thrombosis in the legs, the combination, that multi-organ ultrasound, is almost as diagnostic as a CT scan. And you can draw up your medications. That means you can increase anticoagulation and go to the other treatment options. Why is that so important to do all of this ultrasound stuff? If you can say, yeah, we can do a CT, it's more exact and it's more safe in a way, in a diagnostic way, and it's more clear and it rules out all of the other things. Well, it's very easy to think, I mean, Mr. Johnson is not too old, and would any one of you love that radiation exposure that all of the CT scan brings with it? You'd rather not if there is another way, especially looking at very vulnerable populations. That is, of course, children, pregnant women. So all of these persons might benefit from a bedside diagnosis with ultrasound. Also, if you have patients who are so unstable that they won't tolerate the transport to the CT scanner, all of these persons might benefit from an early diagnosis, or at least narrowing down the differentials very quickly. Okay.
There was another question.
Yeah.
If it's the CUS protocol, CUS protocol.
Not specifically. Yeah, you couldn't know that, but I'm not quite a friend of a lot of abbreviations and mnemonics and a lot of protocols. Protocols in itself are a good thing, but they also have their downfalls and their problems that I cannot address in this lecture tonight. But if anyone is very much interested in that topic, of course, you can write me an email. You can contact me via the team and I can address this any further. It was not specifically that protocol, but it might have been. So there are some specific protocols how you do the ultrasound in a crushing patient. There are some for respiratory failure. There are some for hemodynamic failure. And that could have also been the Rush protocol. That is something more famous. Okay, here's another example of how a subpleural consolidation could look like. And also those B lines that again can also appear in congestion, that is pulmonary edema. They can also appear with a pneumonia. So let's go on to the blood gas analysis. In the beginning, we said that a lot of things got worse. And we will just have a short look on what does that mean in that respective patient, at what numbers do we look, and how do we interpret them. And again, I'm moving to the patient record. It might be this here. And we are moving all the way to the blood gas analysis. We are looking at the normal one first. I hope you can see it fine. I'm even increasing it. So we have in the morning, before everything went down south, pH was okay. Oxygenation was okay. CO2 was okay. Electrolytes and everything were fine. Hemoglobin was okay. Lactate was 1.4. And lactate is a very global, very robust parameter of, are things really okay or are things going bad? Not too much else, and it is not pretty specific, and it also has a lot of limitations that you should be aware of. But in that case, maybe it will help us understand how bad our patient is actually doing. As for the oxygenation part, as always, you might have heard it in the earlier lectures as well, we also have to look at what oxygen are we giving the patient. Here we see how much oxygen is in the blood, but we also need in the arterial blood, but we also need to know is how much oxygen are we giving them. If we were administering 100% of oxygen, that would be a bad value. If we are administering room air or just a little bit of an increase of inspiratory oxygen, that would be okay. So let's go to the ventilation parameters all the way up. And we can see here FiO2 inspiratory fraction on the respirator was 0.3. That is almost room air. And with that, we've had a saturation of 98% and everything was pretty fine. Okay, now something happened and we will look at the other blood gas analysis. What we find here is, I'll just let you see the names of the parameters. So let's go there. What we can see here is that the patient became acidotic and they got a worsening of their respiration. The oxygenation is impaired. The CO2 elimination, that is ventilation, is also impaired. They don't get the CO2 out. And what we also have here, they are using up their buffers in the blood. Base excess is more negative. And we have a lactate that is almost 8. That is the part that you just need to get your experience with. Okay, from the books you learn the upper normal limits of lactate and the lower normal limits and all of the stuff. But to get an idea, okay, what is a little bit badness and what is really, really bad, that is something that you get with experience. And a lactate from normal to 8 is pretty bad. Okay, if you have a patient who has been mobilized in the morning, who has undergone some exercise, some physiotherapy, maybe also if they're extubated, some feeding and all of that kind of program that you do on the ICU to move your patients forward, if they've had some stress in the morning, they can have an increase of lactate to about 2 or 3 or something. But an increase to 8 is there is something going on. So that's for the part of how do I deal with all the values and how do I understand that a patient is doing really bad. Now, let's look at more respirations here. And what has changed there? We've said, okay, 80 would be okay if we're about room air. Now, we have changed something on the ventilator. We have moved to a controlled ventilation from CPAP to BiPAP. We have increased the pressure. We have also increased the PEEP. We have increased the FiO2 to 0.8. That is a lot. And we are now having bad saturations, and we are also having a very bad oxygenation. So that tells you that the respiratory component of the patient's compromise is pretty pronounced. That's for the blood gas analysis. Now we are going back to the presentation again. And let me see where there is the presentation. So that's for the blood gases. Something that the anesthetists love is the expiratory CO2. That means on the endotracheal tube, Mr. Johnson is intubated, right? He's ventilated on the respirator. If you connect a CO2 measurement on the endotracheal tube, that should be a gold standard everywhere actually, then you get the value of how much CO2 comes out of the alveoli, out of the lungs, and into the air. And if we look at it here, will we find it somewhere in the record? We can try to see it somewhere. I don't see it. But I will try to get back to the patient record again. Let us look for it. Why is that so important? That is a little bit food for thought, and you might want to solve it yourself. Is there any idea on why anesthesiologists really, really love expiratory CO2? And the one hint is, it's not about respiration in that case here. Does anyone have a clue?
Some Answers: cardiac output, sudden drop in ETCO2 shows a reduced lung perfusion, success of intubation, as ETCO2 is roughly the same as the question. Circulation, blood flow.
Okay.
Oh, okay.
Yeah.
Sign of obstruction.
These are very, very good answers to that question. And that is really also the thing that I was going at. That means anesthesiologists, of course, love the CO2 because it is a gold standard to confirm that the endotracheal tube is in the right place. These are all things respiratory. That also means that you can adjust your ventilation. If the CO2 is high, you will ventilate the patient more and to remove more CO2, right? That is some important respiratory part. But if the respiration itself remains unchanged during an operation, during surgery in the operating theater, or anywhere else, CO2 that is exhaled becomes a parameter of lung perfusion, because only the carbon dioxide that comes to the lung when the lung is perfused can be exhaled. And you were right, the answers were right. If it suddenly drops while everything else is unchanged, that is a very strong clue of badness. Again, something is going on. That can be a sudden drop in blood pressure, in perfusion pressure. That can be a sudden drop in cardiac output. In fact, you can use CO2 in some formulas to help calculate cardiac output. But going back to our patient here, that means we should find that the CO2 drops, the exhaled CO2. And now the combination is important. Obviously, in our record, we don't have a CO2 trace for the exhaled CO2, for the end-tidal CO2, ETCO2. We only have the arterial blood gas analysis, which is discontinuous, of course. In the combination, where we see an increased PaCO2, increased carbon dioxide value in the blood, while we have a low expiratory CO2, that means a lot of CO2 stays in the blood and cannot be properly removed via the lungs. It is not exhaled properly because there is a problem in lung perfusion. So that is a very easy clue, the arterioalveolar difference in CO2. It could be 28, 25, and in the blood we have 56. And that is a very strong clue here. Okay, normally the difference would be about 5 to maximum of 8 to 10 or something. Okay, moving on. What is actually the mechanism of harm in your crashing pulmonary embolism patient? In the beginning, we said respiratory problems and hemodynamic problems. And which one of these will kill the patient? That is the important question. I see something going on in the chat. Is that something that we should consider? Okay, I'm moving on. So the answer is the acute right heart problem will kill your patient first. The hypoxia is not nice, but you can address it in a way with increasing the FiO2. That has already happened here. And it's not the thing that will kill your patient first, but the right heart problem. Hypoxia is the second most badness. What happens if you have an acute right heart dilatation, increased afterload for the right heart, is that you get an increased wall tension of the right heart, an increased oxygen demand of the right heart, and of course, that worsens contractility and right heart output. At the same time, you have seen that, that the left heart is compromised because the right heart is dilated, and the filling of the left heart is getting worse, and that means the output is reduced here. That means you get a bad blood pressure. That again means that the right heart does not get a good perfusion and a good oxygen supply and oxygen delivery. And in the end, that ends up in a vicious cycle or a spiral of death. That is something that can be pretty dynamic. And that means that is really a patient where you should use a very aggressive approach, aggressive diagnostics, and aggressive treatment that cannot wait. And the important thing is that you really act quickly on that. A friend of mine and a very, very talented and very famous medical teacher, Professor Sarah Krager, is having a website that you should look at. And I will put it in the show notes that I will give you the code later, and we will also distribute it with the team. She has a series of lectures on rescuing the right ventricle. And her words are, the right ventricle is a princess ventricle. What does that mean? The left heart can deal with afterload and with pressure problems, all kinds. The right heart is so thin-walled and so weak in a way, we have a low pressure system in the pulmonary circulation normally, that an increased afterload for the right heart, especially in a right heart that is not used to a high afterload, immediately causes collapse and huge problems. Okay, moving on in our patient, we can see here what diagnostics have been made. We will see, if I just zoom in a little bit, ultrasound, echocardiography were performed at the bedside, and a CT scan was also made. We have seen the findings, and then we are moving on to therapy. What can we say about the risk stratification? These are actually two questions or two answers here. The one point is looking at your patient. How bad is he doing? And we were seeing a bad lactate. We were seeing definitely a hypoxemic respiratory failure. We were also seeing a hypercapnia in the blood, acidosis, elevated lactate, bad blood pressure, need for vasopressors and catecholamines. That patient is in danger. Regardless of the patient record on our ICU, there is a method of risk stratification in pulmonary embolism patients, and I will just touch on that quite shortly. If you look at it here, there is red and there is green and there is some kind of yellow. That means high risk, low risk, and intermediate. And the things that define high risk pulmonary embolism look at hemodynamic stability or instability, respectively. They look at right heart dysfunction on ultrasound, and they look at troponin. If troponin is elevated in a patient with pulmonary embolism, that means that it is at least an intermediate or intermediate high risk. If you have hemodynamic instability in your patient record, that is absolutely high risk. And echocardiography performs pretty similar to troponin here. And, you can make these things more complicated, but I just wanted to give you a clue on how you think about those patients with pulmonary embolism, because on your ICU, you will do CT scans for other questions like pneumonia or something. The radiologist will call you and say, by the way, the patient also has pulmonary embolisms. But these will be peripheral or subsegmental or somewhere else, not that massive as in our patient. And you can use this risk stratification to understand what does that actually mean. Okay, there are also some scores that you can use where some parts of patient history and the current situation are considered. I'll just go over that. And let us look on what we can do to help this patient. First things first, of course, you will secure oxygenation. You've seen in the patient record that the inspiratory fraction of oxygen has been increased. FiO2 was increased. You will also start or increase anticoagulation. Why not? I mean, there are clots in the pulmonary vasculature and in the deep veins of the leg. And of course, you need to treat these with anticoagulation. But you will also have to support the right ventricle hemodynamically, and you will have to avoid harm. What is the special thing about helping the right ventricle and avoiding harm? Let us stop for a moment and see what a pretty monosynaptic reflex, not only in anesthesiologists, but in all kinds of acute and emergency physician is. What is the normal reaction to a bad blood pressure? And even some guidelines on certain things in the ICU tell you to do so. So what is the thing is, you go to a patient, you see their blood pressure drops, and the very first reflex is a pretty monosynaptic one. What do?
Catecholamines, fluids, noradrenaline, infusion, EV, fluids. Yeah.
Yes, and the fluids. Fluids is the normal reaction. So bad blood pressure, everyone who does anesthesia in the operating theater, of course, you would say, yeah, the patient was fasting. Now the surgeons caused the blood loss. What is the problem? Hypovolemia. Let's give them fluids. That is one part of the normal reaction to a bad blood pressure. The second part is cranking up the norepinephrine. Norepinephrine or noradrenaline is the vasopressor of choice for all kinds of problems with the blood pressure. It's a first-line agent that we use in the first place. Did our patient receive norepi? Yes, he did. And what was the team doing that you can see in the patient chart? They increased the norepinephrine. I'm not saying that this is wrong. In fact, it is right most of the time. That is something to start with. But I want to draw your attention to the very special right ventricle, who, we remember what Sarah Crater said, is a princess. We don't want to harm further. And the spoiler is a fluid bolus and cranking up the norepi more and more and more and more really harms the right ventricle. Let's see what you do if your engine lamps go up, if they light. So you have some warnings here on your engine when you're driving a car. What do you do normally? You pull over to the roadside and you stop and you want assistance. What do we do with the hemodynamics of Mr. Johnson? Well, we give fluids, we give norepi, we crank norepi up. In a very, very crashing patient, we also give adrenaline. What is the difference? The adrenaline increases inotropy. It is an inotrope as well as a vasopressor. In our patient here, he received norepinephrine and dobutamine. And dobutamine is a inotropic agent. It increases contractility. The combination is some kind of okay. The undifferentiated increasing of the norepi dosage, like it didn't help enough, so I give more, is not a good thing for a right ventricle. Why is that? Because noradrenaline not only acts on the systemic vasculature, but also on the pulmonary vasculature. That means it increases pulmonary vasoconstriction. Now we have obstructive shock physiology. We have a clot in the pulmonary arteries. And now we give a pulmonary arterial vasoconstrictor. That means we even worsen right heart strain. And I just want to draw your attention to that fact that the normal reaction of giving fluids and giving norepi to a sick right heart is not okay. It's okay in most cases, but not in a sick right heart. And here it is in words: we should avoid harm. We should restrict fluid administration unless there are also signs of hypovolemia in a trauma patient. That is a pretty rare combination. You should not just crank up the norepinephrine. And you should also be very, very careful about sedation and even endotracheal intubation, positive pressure ventilation, increasing the PEEP, because there is a trade-off that you can increase the right heart afterload also with positive pressure, with increasing positive pressure aggressiveness. With sedation, you mitigate the endogenous catecholaminergic tonus. And that also can be the little drop that leads to the overflow of problems. Okay. If you want to do something good for the right ventricle, you would indeed need inotropes, medications, catecholamines, that increase right heart contractility. That is dobutamine, phosphodiesterase inhibitors, that is milrinone, or epinephrine in the most crashing patients. These, of course, also come at a price. But if you have a crashing patient whose right ventricle is in trouble, they will need inotropes. Regarding the vasopressor, if we say norepinephrine might be a good idea to some extent, because we need to keep up the perfusion pressure for the right and the left ventricle, we need some vasopressor. If you have a choice, if you have it in your ICU, and if you can afford it, vasopressin will be a better choice because it does not increase pulmonary effluent. You can use pulmonary vasodilators that act on the pulmonary vasculature, and that is inhaled nitric oxide as an example. This is just to give you a few examples. We are running a bit out of time, and that's why I'll go over it shortly. But these are the things that you can do. Avoid fluid boluses, avoid cranking up the norepinephrine, give inotropes, use vasopressin, and use some kind of agents that act on the pulmonary vasculature and that give you a pulmonary vasodilation. The elegant thing about inhaled nitric oxide is that it is administered via the respirator. That means it comes to the lungs, but it does not act systemically and give you systemic vasodilation that you need to counteract again. Okay, there are also some advanced options on buying time for that patient. The first thing is, of course, you will need some kind of anticoagulation. The Maslenitsa bridge was replaced by a little improvised bridge during the wartime. This is a military bridge, a pontoon bridge that gives you a little bit of options to, cross that part of the sea here, and to use it as a help until you can go to a more definitive solution. So you have a hemodynamic collapse of your patient, you give some anticoagulation, and you go to the rescue to the clot resolution. The worst thing that can happen in pulmonary embolism is cardiac arrest. And there is just a few impulses here on that topic, is that it was found in the resuscitation guidelines and in the most recent also, it was written that right ventricular dilatation in isolation should not be used to diagnose massive pulmonary embolism. That means in almost every cardiac arrest, at one point of time, the right ventricle dilates just because there is not enough forward flow. In earlier times, we said, hey, I got the ultrasound. The patient is in cardiac arrest. I see a dilated right ventricle. Let's pull up thrombolytics because it must be a pulmonary embolism. And research has shown that that is not the case. So be careful with diagnosing pulmonary embolism just because you see a dilated right heart. I just wanted to draw your attention to that little topic here. Something that comes down to my very own profession a little bit more is that you can also use ECMO in crashing pulmonary embolism patients, including those who went into cardiac arrest because of pulmonary embolism. That means you can cannulate their vessels. You should not use the clotted femoral vein, of course, but you can cannulate their blood vessels and you can drain the blood from central veins. You can pump it through an oxygenator where the gas exchange happens and pump it back to the body through an arterial line in the descending aorta or in the iliac arteries. And you can replace all of the cardiac output using an ECMO circuit. That can save your pulmonary embolism patient. But of course, that is only available in parts of the world and in parts not in every clinic. I just wanted to tell you that this is a treatment option. When you think of how should I treat my crashing pulmonary embolism patient, you can go for anticoagulation, of course. You can go for thrombolytics. But if you think thrombolytics, also think ECMO and maybe even ECMO before thrombolytics, just to stabilize your patient. That is a matter of availability in your shop. How fast can the patient be on pump? Because the combination of ECMO and thrombolytics is a big mess that increases bleeding risk a lot, especially in a trauma patient. But this is also another topic for another night. This is how an ECMO works. Yes, please.
Two questions. How would you measure the inhalative INO success? Would you use a PAK in a patient where you administer inhalative nitrous oxide?
That is a very good question. A pulmonary artery catheter is, of course, normally used to measure pulmonary arterial resistance. But in a pulmonary embolism patient, I would not place a pulmonary artery catheter. If there is already one in place, we can use it to understand things. It would likely show us early signs of increased pulmonary arterial resistance, but it is not something that I would really place in the first part in that patient. So we need another way to understand whether the patient is getting better with our therapy, and that is oxygenation will improve. Also, ventilation will improve because we will decrease the parts of the lung that are ventilated but not perfused. We will improve the ventilation perfusion matching. We will see a dropping lactate and all of the things that show you that the patient is getting better, along with monitoring with echocardiography. So that would be my go-to in that patient.
And there was another question if you would use VV cannulation or VA in case of ECPR.
Oh, that is a highly discussed topic. Normally, you would say the logic tells you the bad hemodynamics is killing my patient, and VV ECMO does not heal a bad hemodynamic. VV ECMO, veno-venous ECMO, is just a lung replacement, so it does not help my pulmonary embolism patient. If you want to rescue someone who has a bad circulation, you need VA ECMO, veno-arterial ECMO. So that is hemodynamic replacement and therapy. But there have also been some publications recently who say, even VV ECMO could be helpful in a way. They showed it in a patient collective, but that is also something that widely surpasses on what we are talking about tonight. For the interested ones, there is some dynamic in that issue. Of course, veno-venous ECMO will improve the lung part. You will also give more anticoagulation there, so it could be helpful in a way. But in many VV ECMO patients, sooner or later, a right heart problem occurs in addition. So that is a very complicated thing. And I would go for VA ECMO first.
Okay.
Just to round up that eCPR thing, so if you have a crashing pulmonary embolism patient who is collapsing, who needs CPR, and you understood that really thromboembolism is their problem, the HSNTs boil down to thromboembolism, then you can use eCPR, you can stabilize them, and then you can go for further treatment options and for recovery. Yeah, there is also a surgical therapeutic option, Trendelenburg operation. That means you just cut it out. Yeah, you open the chest, you open the pulmonary artery, and you pull out the embolus. You can do that using a cardiopulmonary bypass. This is an anesthesiologist, intensivist, and this is a cardiac surgeon. And he asked them, "Would you like to pull it out?" And the surgeon says, "I love to." And you can do that. In older textbooks and in my studies, I was taught actually that Trendelenburg surgery is some kind of ultimately last option. It's a rescue option, and lethality actually is high, up to 50%. That is not true today. That means you can do it in a more safe way, and lethality is not as bad as 50%. Of course, it's still a high-risk situation that you are going for, just to have mentioned it. If we go for treatment principles and options, we are talking about anticoagulation. We are talking about thrombolysis that we can administer systemically. That means we give it via the central line, or we can do it catheter-guided. In that instance, not the intensivist places a pulmonary arterial catheter just like we do it all the time, but you go to a fluoroscopy, you go to a cath lab, and it is placed under fluoroscopy, very much like a pulmonary arterial cath. You direct a catheter right into the pulmonary vasculature, and then you can administer thrombolytics there. You can even today have a catheter placed in the pulmonary artery, and you can try to suck out the blood clot. That is called mechanical clot removal. That is the most recent innovation in interventional treatment of pulmonary embolism. There is a lot of discussion there. The first data are promising, but the evidence is not as robust as of today as it should be to give a general recommendation there. There is a lot of interest in that topic, so you can use a catheter, you can direct it into the pulmonary vasculature, and the interventionalist can pull out the clot and stabilize your patient. That is something that you should stay tuned. Filter placement in the inferior vena cava is something that does not happen all too often, and it also has their drawbacks, something that I'm not very familiar with. I just wanted to mention it in the list of the treatment options. If you look at the current recommendations, I apologize, there have been more current ones, but it's pretty much similar. You have here the recommendation list. You can look it up. There is green, there is yellow, there is orange, where all of the things that I told you about are summarized in a more differentiated way, and they are also weighted. Of course, and Mr. Johnson, things can be very complex because you need to stratify on how aggressively will you anticoagulate him. Can you give him thrombolytics if he is a polytrauma patient having undergone surgery very recently, so they have a considerable bleeding risk, or should you go for the other treatment options? Also, one recent thing is that you use lower dose thrombolysis, and there are also some data on these, but you really have to look into the respective patient sample that was used on. You have to look at the risk stratification on how bad is the pulmonary embolism for my respective patient in front of me. You have to look at all the available reperfusion strategies and what you really have in your shop.
There's just a question to crashing patients. Should a transfer to ECMO eCPR capable center be considered if their own hospital doesn't have the skills and equipment? And in this case, should the hospital from which the patient is departing already start the lysis therapy?
Oh, that is the toughest question ever. Thank you for that question. It's super logical, and that is the thing that gives us nightmares. There is not a, as to my knowledge, there is not a specific recommendation on that kind of patient because everything is just bad. If you start a thrombolysis on the way in a trauma patient who has had surgery, that is bad. If you combine it with eCPR, it is bad. But if you don't, they will die anyway. So it's the toughest question of all in this very patient, and I have no real answer for that. I'm sorry to leave you with that uncertainty, but that is the thing that I'm afraid of myself. Because if a patient is doing that bad, maybe they won't survive the transport. If you have no other option, the first thing to do is to talk to the ECMO capable center. So if you take something away from tonight is think of it. So if you have that patient in front of you and you think that they won't survive the next few hours if we don't act on that, and I'm afraid that thrombolytics won't help in themselves or they are too dangerous, just call the ECMO center and talk to those guys. Most of those also have retrieval programs. That means they come to your shop and they connect the patient to the ECMO circuit in the hospital where they are, and then they can transport them. That is very often the case. I would like to wrap up all of the story, and in that case, I would also thank you for your patience with me because we are over time. I hope it was as interesting as it was for me and fun. Look at all those bridges here. I mean, what did they do after the wartime? They, of course, built the Maslenica Bridge. They rebuilt it. And what happened is that is a motorway bridge. And on the motorway, you have to pay toll to cross it. Many of you will know that in their own countries. So you have to pay to cross the motorway. That made the big circulation happy. So the big circuit was okay, but the local area here, the small circulation, they were not happy because if those folks just need to cross the bridge to go to the supermarket here, and they always have to pay, they are not happy at all. What did they do? They built a second bridge here, right? So sometimes it's important to have more bridges to secure things and to make not only the macro circulation, the systemic circulation happy, but also the small circulation, the pulmonary circulation. Okay, I would like to conclude that you have learned some clues that can help you recognize whether the patient has venous thromboembolism or some other problem. They can also help you recognize and stabilize your very crescent patient, and you have understood how you can do it and how you can avoid harm. What is so special about pulmonary embolism patients? It's the right heart, and you can harm the right heart with your monosynaptic reflexes of cranking up the norepi and giving fluid boluses. You have also learned that multi-organ approaches, especially in point-of-care ultrasound, make sense to narrow down the differentials in so complicated patients. If you think thrombolysis, thanks again for the question, think eCPR, think ECMO. So if you have a patient where you think, I shouldn't need to thrombolyze them, but somehow, is there another way to help them? Contact the ECMO-capable team in your shop or in another hospital. And if they say, no, we can't help you, then you can still move forward, but you should take that minute. Just think of it. And of course, I cannot leave you without telling you point-of-care ultrasound is your very friend in acute and intensive care and emergency medicine. With that, I have finished my presentation, and I'll be happy to take further questions if anyone still likes to hear something.
Thanks a lot. There's just one question concerning increased venous, lower systemic blood pressure and increased venous pressure and preload to make it easier for the heart to pump the blood from the right to the left. if that makes sense. Does that apply in the case of the pulmonary embolism?
Okay, the right heart is very sensitive to afterload, but to preload as well. That is true. And there is some teaching that in right heart infarction, preload can help a bit to move things forward, but that is not true in pulmonary embolism. So you should not try to increase preload in pulmonary embolism. You will just make things worse, because if the right ventricle dilates further, it can happen that from one dilatation they are consistently damaged, and that is irreversible. So just don't try to. You can do your testing. You can try to do a passive leg raise and see if it helps something. So this is kind of a reversible test of fluid responsiveness, but that will not help you actually. So in right heart infarction, we can talk about it in a way, but in pulmonary embolism, no way.
Okay. Somebody mentioned the Wells score. Will you calculate it for recognition or the risk of a pulmonary embolism?
For training reasons, maybe, but I don't do it.
Okay.
I would use the other scores like PACE and stuff like that, which are also mentioned in guidelines for critically ill patients. You know, the Wells score is for all comers in the emergency room.
Mm-hmm. Another ECMO question. ECMO is associated with many complications like bleeding and hemolysis. Does ECMO statistically offer a survival advantage?
That is also a good question that pertains to the current state of the evidence and literature. And there indeed are some studies, some of which were performed by a friend of mine in the Netherlands. But actually, yeah, there are some data that there is improved survival, but not too robust, because this is a very special and very small patient group.
Mm-hmm. Okay, next one. Would hemodynamically stable patients benefit from non-invasive ventilation?
Well, in a way, to improve oxygenation, you can try to do it, because many of the patients don't only have pulmonary embolism as their respiratory problem, but they also have atelectasis and all of these things that you can, in a way, improve with non-invasive ventilation. So you can use it to improve respiratory failure, but be careful with the pressure. It still is a positive pressure ventilation, and don't crank up the pressure indiscriminate, because you can also increase intrathoracic pressure, be aware of air trapping and all of these things that can harm the right ventricle further.
Okay. Last last two questions. Is there a role in scanning the IVC in diagnosis of PE, and is it useful in intubated patients?
Yes, it is. It will only be part of the jigsaw. It will be one piece of information that will help you. Scanning the IVC in itself can show you a clot. If you happen to see a clot in the IVC or in the right ventricle or so, you will have the immediate answer. You will see the clot. And also, it is more unlikely to have a very small IVC and a crashing relevant pulmonary embolism. So these things don't quite go together. In some cases, it can still happen, but normally a flat, small IVC will not be consistent with a crashing relevant pulmonary embolism. Definitely makes sense to scan the IVC as part of the jigsaw.
So we will close with the last question. Did I get it right that you are deciding in favor of eCPR? You are for the moment deciding against thrombolysis because of the bleeding risk?
Definitely depends on the patient. If it's an internal medicine patient who just has thrombosis everywhere, who is on the very clotting side of everything, then I would not be too much afraid of bleeding. And then, of course, I would go with thrombolytics because they are the fastest things that you can do in very massive pulmonary embolism. It's the first thing you get on your ICU, right? It's there. You have it in the cupboard. You just pull it up. You give it in a trauma patient, in a surgery patient, post-surgical patients who really do have a considerable bleeding risk. And I have the ECMO in my shop, so I know where the team is. Maybe, as for myself, I can cannulate myself. Then, of course, I would try to put them on the pump first because that gives you anticoagulation anyways, and that stabilizes the patient hemodynamically. And then I can bring them wherever I need. I can still give thrombolytics, maybe with a reduced dose. I can do some diagnostics. I can bring them to the cath lab to do clot removal and all of the like. So I would reach for the ECMO first if I know the patient is on pump quickly. If I'm pre-hospital somewhere, that's a whole other story. So the answer is depends.
Thank you very much. It was a wonderful session. I think all of us learned a lot, and we're very happy that you got us the opportunity to learn from you and to learn from your examples and your very good ultrasound pictures. And yeah, thank you very much.
Thank you as well. Thank you for having me again. And I'm really looking forward to more stuff. And I'm also watching all of the other lecturers with great interest because the format is just great. The lecturers are great, and the team as well. Thank you so much. All the best to you.
Have a great vacation.
Enjoy your holidays.
I do. Bye.
Bye.